Blog Talk Radio.
Welcome to today's episode of Inpatient Myeloma Radio, a show that connects patients with myeloma researchers. Through this series, we are learning about the very latest in myeloma research and learning about clinical trials that are moving us closer towards better treatments and a cure, and how we can participate to drive towards that cure. If you'd like to hear about the very latest in a weekly email about the interviews, we invite you to subscribe to our Inpatient Minute newsletter. Just go to the homepage, www.mpatient.org. You can find links to our Twitter and Facebook pages there as well. Thousands of you have listened in to past episodes, and the numbers are quickly growing. I notice that as we become more educated about myeloma, we start asking more questions. The most important question I hear is, what does this mean to me? We all want to know how to make the flood of information personally relevant. This is not an easy thing to do in myeloma, because we hear that all myeloma is different, and that the disease can change over time. Today's interview is with Dr. Gareth Morgan, not only a myeloma specialist, but one who is looking to answer this important question: how can we achieve personalized medicine in myeloma? As an introduction for Dr. Morgan, I'd like to describe his background a little bit. Dr. Gareth Morgan is a professor of hematology at the Institute of Cancer Research and is a consultant hematologist at the Royal Marsden NHS Foundation Trust. After attending medical school at the University Hospital Wales, he completed a PhD and trained in the molecular genetics and management of blood cell cancers at the ICR. He left the ICR to join the University of Leeds, where he set up his own research group, studying the molecular genetics of non-Hodgkin's lymphoma and myeloma. He is an internationally respected clinician and researcher who has published extensively on the genetics and treatment of these diseases. His research focuses on using new targeted treatment strategies based on a deep molecular analysis of individual myeloma types using newer diagnostic tools. One of the major aims of his research group is to develop personalized medicine strategies for myeloma with the aim of overcoming treatment resistance. He has run and continues to run a large number of clinical trials and uses his discoveries in the clinic. He is widely published with over 400 articles. He is recognized both nationally and internationally, and has been scientific secretary for the British Society of Hematology. He is currently scientific secretary for the UK Myeloma Forum. He reviews for a number of journals and sits on grant-giving bodies both in the UK and internationally. He has been instrumental in creating the European Myeloma Network. He is a director for Myeloma UK, scientific advisor to the IMF, and is on the board of the UK Stem Cell Bank. Now, because Dr. Morgan is located in the UK, we are going to give him a minute. And Dr. Morgan, do we have you on the call?
You do.
Oh, I'm so pleased. Your timing couldn't have been better. Thank you so much. I'm so glad you're joining us.
No,
all right, well,
thanks for the invite.
Well, thank you for joining us. So now, I gave a little bit of background about you, a short bio, and when I hear patients ask questions, you'll go to patient conferences, or you'll be, on my website or other websites. Most of the time, patients will say, I have this kind of myeloma, I've gotten this kind of treatment, and really, what does all this information mean to me personally? They want information and help that matters to them.
Yeah, absolutely.
So I know that your whole approach is to perform personalized medicine for myeloma, and I think it's a very bold and wonderful approach, and I'm very excited that you have that approach. So maybe you could give for everyone just a background first of the approach and what your research is trying to do overall, and then we can get into a lot of detail because we have a lot to talk about.
Okay, so I guess the best way to describe it is that everybody sees myeloma. You look in the bone marrow, and what do you see? A sort of plasma cell. It looks like a plasma cell. It looks like a malignant plasma cell, and you get a diagnosis of multiple myeloma. There's a lot more detail that you should superimpose on top of that now. So, we know that some patients with myeloma won't respond to treatment. Some will respond and relapse quickly, and others will stay in remission for years and years and years. So almost by definition, myeloma is not a single disease. It's a group of diseases with different prognosis, different natural history, that all just happen to look like plasma cells. And so the real thing is we don't understand the language of plasma cells to be able to separate the different risk groups. So really what I kind of like to do, or try to do, is to understand a sort of language you can superimpose on top of just looking at the plasma cells that will say, this is a patient who will respond well, this is a patient who will respond badly, this is a patient who will have more bone disease. And I think it's coming to a stage now where we have the tools to really answer those questions. And so that's what personalized medicine is. At one level, it's about who has high-risk disease, and I think we're at a time now where there should be tests applied to define if patients are high risk when they're first seen. And then beneath that level, there's what molecular subtype, and we can use that information to design specific treatments for those molecular subtypes. So that's really what I try to do.
Well, it seems a lot of that is based on the diagnostics, and then I was reading about your group that you were using some newer diagnostics. So can you tell us what tools you use to try to determine the subtype of myeloma?
So there's a variety of tools. So one of those tools is called iFish. iFish is a technique that's available more or less globally, and there are a kind of maybe 6 important prognostic factors that you can detect with iFish, and you should have a panel of tests for all 6, and then you can define the risk of the patient, because if you have 1 abnormal lesion, you do pretty good. If you have 2, maybe not so good. If you have 3, you really need to consider the type of treatment that you're having. Then we move into the sort of molecular world, and there's a test called RQ-PCR, which you can use to define many of the risk variants associated with myeloma. And it actually turns out it's not a very expensive test and is applicable. And the third level are these gene expression profiles. And there's been good work done by ourselves, the group in Arkansas, and people in the Mayo, that identify signatures of people who have high-risk disease. And maybe 20% of people at presentation can be identified as having really poor prognosis disease, who do badly with current treatment strategies, that we should be altering the treatment approach as soon as we know their risk status. And that's about state of the art currently.
Okay, now when it comes to fish, I know that the fish can tell you the translocation maybe that you have, and so can the gene expression profiling. And I know some facilities use one over the other. For example, we talked to the Mayo Clinic, and they really heavily rely on the fish analysis. And then University of Arkansas and University of Iowa always will use the gene expression profile.
Yeah.
So what does the gene expression profile give us over the fish, or what does that give us that's different from fish?
So it will tell you everything that the fish will tell you, but in addition, there are these things called signatures. And a signature is like a group of genes that are over or underexpressed. They put a lot of reliance on the 70 gene signature from Arkansas, and that 70 gene signature identifies people who will have a median survival of 1 to 2 years, in contrast to the rest of patients who will have a median survival of out to 10 years plus. And so the important thing is that if we don't do those kind of tests, you don't know how people are going to behave to start with. And up front is when we should be maximizing the treatment to try and get the best outcomes we can.
And well, I would agree. I guess I've had this test and it was helpful, but I know that some of the physicians will say, well, it's not going to alter your treatment. But if our ultimate goal, in my mind, is to get to a personalized treatment based on potentially specific genes, then wouldn't you need this? I would think that you would need this.
I think we've hit a time where it's very difficult to move forward with this. We continually improving treatments. It's been a decade of great excitement and self-congratulation in a way that things have gone so well. And there are some new treatments around, but they will get increasingly difficult to validate in the clinic. And one of the groups that really is under-investigated and a place where you can investigate new treatments is the high-risk group, because we need specific trials of therapies that actually work in high risk. We don't even know really what the biology of high-risk disease is, and simply investigating that is going to be a big step forward. So, this is a group of patients that needs to be identified, and we need kind of more studies on that group of patients to understand it, and then we need therapeutic trials specifically for that group of patients.
Okay, well, that would be wonderful. And does the gene expression profile, is that what's considered gene sequencing, or is that a different type of test?
No, that's totally... Gene sequencing is the sort of next level of complexity on top of this gene profiling. So the gene sequencing takes all of the kind of DNA sequence from a patient and looks for mutations that are driving the disease. So you hear lots of people talking about driver mutations for myeloma, and we're starting to understand more. MYC is clearly a driver mutation for myeloma, and if we target MYC, I think we'll make some progress for myeloma patients. People also say that there's no unifying mutation in myeloma, and I'm starting to think that's not correct, because in maybe 50% of all myeloma cases, there's a mutation of a gene or gene pathway called the RAS pathway, and that, I think, is a driver mutation, and I think it's a pathway that can be targeted. And so the beauty of these mutations is, if they're driver and you understand how they're working, you can design treatments specifically against that pathway, switch the pathway off, and get patients into a remission.
Mm-hmm. Now, well, I want to share with you, I guess, one of the reasons, or the biggest reason, that I wanted to interview you. I think patients are, hoping and praying that we find this needle in the haystack. And one day I got the Wall Street Journal, I opened it, the front page had a story on it about a patient who was looking at a gene-specific treatment for her lung cancer. Mm-hmm. And the article talked about the ALK gene, the KRAS gene, the EGRF gene, and I can't even share with you how profoundly I was affected by that article. I just kept coming back to it on my kitchen counter, thinking, this is really significant. So I thought, I wonder if these genes are applicable in myeloma. So I started doing some searching online, and which led me to you and your group. Mm-hmm. So that is one. I just feel that what you're doing is very, very significant. So a question about that, if we know that, I know that some of these translocations, like 414 is not a great one to have, and then it's associated with MMSET or FGFR3. Have we, if all myeloma is different, have we matched up different genetic mutations with different translocations?
So the 414 translocation you're talking about is one that's sort of dear to my heart in a way. It is a poor prognostic lesion, but I think it's really, really important to say that not all patients who have a 414 do badly. And if those patients are treated well, and one of the dogmas is that they seem to do very well with the introduction of proteasome inhibitors like Velcade, that is one reason for identifying that subgroup of cases. The other is, you rightly say that translocation deregulates two genes. We used to think it was FGFR3 that was the target, but it's pretty certain that it's MMSET that's the target. And so there are at least 2 or 3 different academic groups around the world that are trying to make drugs that specifically switch off MMSET. And while we don't have those drugs as yet, within the next year we will have drugs, I think, that are able to switch off MMSET. And because it occurs early on in the natural history of myeloma, hopefully that's going to put people into a remission. And so that's a fine example of personalized treatment that is going to work in myeloma. The other example is, we made this test looking for chromosomal translocations, and we found a specific translocation that was exquisitely rare, may have been a one-off, that overexpressed the EGF receptor gene. And the importance about that is, if you had known that for that patient, EGF was overexpressed in that patient, there are drugs that are available for colon cancer that may have worked for the patient with multiple myeloma. And so identifying actionable mutations where a treatment already exists in another disease, like ALK, say, and then translating that into myeloma, is really of potential importance, I think.
Well, and that's what this patient was trying to do for lung cancer. She was drumming up people who were doing research for that particular gene mutation in other cancers, and she was really inserting herself into their clinical trials.
Yeah, no, I think it's, there's only one trial that's really gone that way as yet, but over the next years, I think instead of people treating diseases in a way, there's going to be a lot of interest in treating mutations, because what works for a mutation in one disease should work for a mutation in another. That's the hope.
Yeah, and now how is a gene like EGFR or other ones like MMSET or the others identified? By which test specifically?
So you have to look for specific mutations, and so it's sequencing in all its forms. And so the question with that is, do you do a global test that identifies every mutation in every gene, or do you come up with a list of actionable mutations, maybe 40 to 50 genes, where you just look to see if those genes, which are kind of modifiable with treatments that exist now, are present. And those kind of tests already exist. There are sort of companies that provide those analyses in the US.
And can we go backwards a little bit? Because I was familiar with the RQ-PCR test you talked about. Can you explain what that test is and what it does?
It's basically a kind of laboratory test that can allow you to ask if a limited number of genes are overexpressed. And so you can design them that are relevant for myeloma. So if you want to know how to classify your myeloma in a very simple way, based on like the TC classification, you can do that for a relatively small amount of money, do something that will turn around, give you a result within 48 hours, and you can do that and know what subtype of multiple myeloma you have, which translocations are present, and how the disease is likely to behave. Again, it's faster, more robust, more throughput than doing the iFish tests. And it's applicable to smaller numbers of cells as well, which is important.
And does everybody do this test, this diagnostic test, is this being done everywhere that you know of, or is this new? Or
No, it's new. So what we're trying to do, which is easier said than done, is to actually make these tests robust in the clinical environment so that you can regularly get them. We can have all of our patients get a result of such a test and avoid this, oh, the fish didn't work, oh, we didn't have enough cells, because there's a lot of problems around getting adequate cells, getting a result in a meaningful time frame, and it's not standardized. That's a really important thing to say. There's no really global standardized approach, and we need to work on that kind of standardization.
And who provides this RQ-PCR test? Do multiple providers sell this test, or? No,
it hasn't got out there to provide. It's rather easier for the providers to go along gene expression profiling, but hopefully within the next year, the people from Arkansas will be working on kind of moving some of these tests out into the kind of general arena where patients from around the world will be able to get this kind of analysis done.
Well, my doctor likens it, myeloma, to fighting a war, and he just
not a short battle.
Yeah, and he just says, you need to know as much about the enemy as you possibly can. So he was very focused on the diagnostic testing to provide as much information as possible, and that was a much better approach than the general oncologist that I started out with, that took a blood sample and said, I think you have myeloma. We'll start you on Velcade on Friday. And I said...
I agree with you. I think it's a really interesting concept, because the old-fashioned approach was, it's myeloma, we treat myeloma with Velcade or Revlimid or transplant. Not do any risk stratification, just one size fits all. And as soon as you start thinking about it, it doesn't make any sense. It's a kind of scary disease. It is a bit of a battle, and the more that you know, the more empowered you are to make the right treatment decisions. And the next few years are going to see an explosion in small molecule therapies that target specific kind of cellular pathways. And if you know those pathways are deregulated in your disease, then it exists as a possibility. Knowledge is power, and I think you want to be empowered as a myeloma patient.
Well, absolutely, and I think if I had the 414 and set, I would do a lot of personal research on that one. I happen to have the 1420 MAF-B, which is not very common. And
less than 2%.
Right. And so for me, I would like to track that particular one down, because, maybe the other genes don't have anything to do with me personally. And I know every time patients just ask that question, how does this relate to me personally?
No, it's kind of, I think that's a very good statement. For you having MAF-deregulated myeloma, there's a whole series of information about that type of myeloma that I think is relevant. Least of all, there was a paper like last year or the year after in Blood from an investigator called Annunziata who works with in the NCI, I think, in Bethesda, and they showed that MEK inhibition may be a particularly good way of targeting MAF-deregulated myeloma. So it's not relevant to all myelomas. Yeah, so I think that's worth looking at. And that's not doesn't mean it will necessarily work for you, but at least you see that people are specifically working to find solutions to the MAF subtype of myeloma.
Well, I think that every patient should do this individually because not all myeloma is the same, and it is a very empowering feeling to know more about your disease. So,
yeah, I kind of don't. I'm not sure. It's like one size fits all. Some patients prefer to bury their head in the sand, but actually, the people I think that kind of really do dig into their disease actually do better long term.
Well, I did that for the first 2 years just because it's too overwhelming and everything is so new. But I think you go through phases, and it's good to have an empowered, educated phase.
Yeah, no, good for you.
I'm having that phase right now. So I know that you are studying how myeloma progresses, the factors that turn MGUS to myeloma or to maybe smoldering or to full-blown myeloma, and the progression that turns smoldering to myeloma. So can you share with us what you found?
So, I've kind of gibbered on a lot about mutations and the role mutations have in driving cancer forward. And I was kind of determined to find the mutations that push myeloma forward, because if you can find those mutations, those are the ones that you should target. And we asked a really specific question. So for patients with smoldering myeloma, and smoldering myeloma shouldn't have any end organ damage, what makes those patients turn into myeloma where suddenly they start to have lytic bone lesions, anemia, bone pain? So what causes the symptoms? And the hypothesis was simple, was that there'd be one or two mutations that actually cause that kind of transition, and they'd be targetable. What I was surprised to find was that we didn't really find a clear answer, and that raises the issue of what is it that the cancer cells, the myeloma cells, are doing to the microenvironment, the surrounding cells that nurse and keep the myeloma cells alive. And I think there's the potential, at least now, that the cancer cells modify their environment, and as time goes on, it reaches a critical stage beyond which the myeloma cells suddenly get switched on into a more proliferative state and rapidly grow, and it's that transition that's mediated by the microenvironment rather than by a kind of series of mutations in the cancer cell itself. So I think the conclusion to that is there are mutations that push the disease forward, but also the microenvironment in the bone marrow is really important in the transition as well.
Well, can you talk for a little bit, because that's called, let's see, I have it written down, is the NF-κB pathway. Is that the bone marrow environment, or is that what regulates that environment?
It's what regulates that environment. So NF-κB is one of the important pathways that we can target in myeloma, and at one level you can target NF-κB with proteasome inhibitors, Velcade. And so I think there's a whole kind of series of work now that goes on that building on the next generation of proteasome inhibitors and inhibiting molecules that are upstream and downstream, so as you can get effects in plasma cells. So the NF-κB pathway is a really important pathway that lots of people work on and try to target.
Okay, well, is there anything else that affects the bone marrow environment or that's causing that we should be aware of?
I think we need to understand it, but I think there's the potential for the myeloma cells to secrete factors which modify the stromal cells, and so the MAF thing is an important thing in terms of the microenvironment. I think it's integrin beta 7 that's upregulated by the MAF translocation, which makes the myeloma cells bind more strongly to the stromal cells. And when they're bound strongly, they're more resistant to chemotherapy treatment. So if you could use antibodies or molecules that disrupt that binding to the stroma, maybe you'll make the myeloma cells more sensitive to the chemotherapy, and then you'll get a better outcome after your chemotherapy. So that's just one way that you can think of modifying the microenvironment therapeutically to improve the outcome of treatment.
And I know there are a lot of new cell signaling pathway and monoclonal antibodies that's just barely it seems like it's just beginning, and there are a lot of them in the phase 1 kind of approach. Is there such a thing as a monoclonal antibody for a particular gene, or is it just these proteins that are expressed or things that are secreted in the cells?
So it's mainly for things that are secreted in the cells at one level, but I'm no expert at immunotherapy, but it looks to me like there are a number of antibodies now that can improve the activity of the immune system against the myeloma cells. So I guess the paradigm for that was that Revlimid seems to work by enhancing the immune effect against the myeloma cells, and that can be improved by adding in elotuzumab, which is one of the antibodies. But there are now antibodies that are being developed in melanoma and not myeloma that may actually be effective for myeloma patients. And so one of the ways forward to overcome this reliance on targeting specific mutations is to enhance the immune system, which just works against all cells in many respects. And this immune enhancement may be a way of keeping people in remission for a longer period of time.
Okay, and I was doing a little research on just my translocation with that particular gene, and got online and found a site called Gene Cards that tells you what all these genes do specifically. And I found this list of monoclonal antibodies that target that specific gene. So I was just kind of curious, with your genetics background, if you've ever heard of monoclonal antibodies that target a particular gene, like MMSED or something like that.
There's a difference in the terminology. So by definition, monoclonal antibodies are specific against more or less a single target. So if you wanted to stain for MAF, you would use a monoclonal antibody directed against MAF, and you'd be able to specifically see if a cell expressed MAF or not. That may not block the activity of MAF. So you specifically don't want to detect it. You want something that interferes with its functionality. And that may need something that's not a monoclonal antibody.
Okay, well, that makes sense. Now, I was reading on a patient blog that was very knowledgeable, and she was just saying that how MGUS to smoldering and to myeloma is all just sort of progressing towards plasma cell leukemia for everyone. And myeloma is kind of a stage in that. Can you explain what that is? And I guess, is that why after treatment or just maybe time, the disease starts getting more aggressive?
So I kind of need to take a step back with this. So I think that patient is right, that really, we're all dying in a way. It's just the rate at which that happens that's important. And so similarly in myeloma, everybody's progressing to plasma cell leukemia, but the rate is really important. If you've got MUGUS, the rate could be measured in hundreds of years, and for some patients, they never get to that stage. So you need to put it into that sort of context, although conceptually that's right. For an individual patient, that could be very, very worrying that they all think that they're going to develop plasma cell leukemia. So I'd really like to make that point. But if you just take it as a simple concept, then I think it's true, and it's all about evolution. So myeloma is not, even within a single patient, there are different cells belonging to the same type of myeloma that have different mutations, different behaviors, and when you put treatment onto a myeloma in a person, what you do is kill the sensitive cells, and you tend to leave cells that are resistant. And so over time, the resistant cells come to dominate, and that's why people relapse. And it's why, if you have one type of chemotherapy to start with, when you relapse, your doctor will give you a different type of chemotherapy with a different mode of action. And so that's why a lot of the time we've made good progress by specifically getting people into remission by killing cells that are sensitive to different agents. And it's why continuing to find new agents is really important for myeloma patients. Some of the lessons from this sort of it's called intraclonal heterogeneity, are that if you want to get the best results for patients, if you want to try and specifically cure patients, you need to front load the treatment so that you get rid of all of the bad clones that are present as soon as you can, and you don't leave them to strengthen over time. So I'm not sure if that makes sense.
Yeah, it's a more hit it hard at the beginning kind of approach.
Yeah, I think that's one of the lessons from what we're understanding about from this intratumoral, intraclonal heterogeneity that we see.
And then our last interview was about progenitor cells. So have you done any research on how we can not only just get rid of all the fully developed, heavily produced, potentially, plasma cells, but the earlier cells?
So I think I keep looking at this data, and it seems to me that the target in myeloma that we need to kill is a cell that looks and behaves like a plasma cell itself. So I think we know what the target is. It's just some of the cells have the capacity to self-renew and to proliferate. And any cell that has that capacity is capable of transferring myeloma from one place to another. And so we've taken some cells from a patient, put them into a mouse model, and we can clearly see that the plasma cells transmit the disease, and that within a myeloma clone that there are multiple stem cells that have different characteristics. They can have a different phenotype, and they can also have different genetics. And at any one time there are probably multiple myeloma propagating cells, I prefer to call them, that are able to divide, proliferate, and pass the myeloma clone from one place to another. And another thing that comes from it is we all tend to think of myeloma as being a homogeneous disease that's a bit like leukemia that's in the bone marrow. But actually these new scans that we're doing, like diffusion-weighted MRI, actually show us that I think myeloma is like a metastatic disease where you have a tumor at one site that can move to another site, that then can move to another site. And these focal lesions that we see in the myeloma patients' bone marrows with these technologies are actually the site of myeloma propagating cells cells that have different characteristics to the rest of the marrow, that we really need to understand the biology of these cells.
Now, when you talk about the mouse model, have you taken an MGUS or smoldering type myeloma and tried to put that in a mouse and then try to add things to it? My very unscientific way.
Kind of been, yeah. We did like it was mainly with cell lines that we could if you can inject the cells directly into the mouse leg bone, you can get good engraftment, and so we did this with several plasma cell leukemia patients, and we're able to get good engraftment into the mouse, and that's where that data from the heterogeneity in the myeloma stem cell comes from. Because to the best of my knowledge, nobody has really done that type of experiment, looking at the genetics of what are present in the mouse when the mouse has been engrafted.
Well, I think it'd be really interesting, because I know, you look at studies that show certain lines of work, like farming or something that has, and maybe there's something being added to that mix that's the trigger. I don't know, but that could trigger it to progression, but I'm not sure. Well, you had an article in August that came out about the TERT gene related to myeloma and aging. Would you like to share what you found for people who have not had a chance to read that article?
Do I want to share that? Just remind me exactly of the context that you're asking. Which study was this?
Oh, it was an article that came out about myeloma and the gene for aging. And it said it brought the number of genes that we know about myeloma to 7. So I was kind of curious about what those 7 are.
So the bottom line of this was that one of the things that patients always ask is, why have I got myeloma? Why me? And there's a tendency then to focus on things in the environment. And we've done a lot of studies on what causes myeloma over the years. But really, nobody has come up with a good environmental cause for myeloma as yet. So in order to try and understand what the factors are that may predispose people to develop myeloma, we did a study which is called a GWAS analysis, where you take hundreds of patients with myeloma and compare their genome to hundreds of people who don't get myeloma. And if you see associations with specific genes in the patients with myeloma that aren't present in the normal controls, you know that they predispose to myeloma. That's basically the scientific approach. And so we did a number of those studies and found genes that seemed to predispose people to developing myeloma. And we found 6 genes in total which seemed to predispose an individual that has that genetic makeup to developing myeloma. The risks for any individual are not high, so people shouldn't worry that they're passing the risks for myeloma onto their children, because these are genes that don't really behave in that sort of fashion. So there are now 6 genes which seem to increase your risk of developing myeloma that you could actually look for in the cells that you have that are not cancerous. The interesting thing is, one of the genes, so you talked about translocations, and you've got a MAF translocation. Well, there's a translocation called the 1114,
right,
which actually deregulates a gene called cyclin D1. So that's kind of interesting, because if you inherit a variant in cyclin D1 that you can measure, your chances of getting a translocation into the gene in your myeloma are increased substantially. And so there are genes now that predispose you to getting myeloma and genes that predispose you to specific molecular subtypes of myeloma. And it's probably not one single gene. There may be as many as 20 or even more that contribute to the risk in an individual. But across a population, they really do start to explain some of the reasons why there are people who develop myeloma.
So cyclin D1 and 1114 is a less aggressive form of myeloma from what I understand, right?
Yeah, that's right, yeah.
Okay. And more people have that, it seems like.
Yeah, about 20% of the total.
Mm-hmm. And could you name off the 6, if you don't mind?
No. my memory doesn't stretch to that, and if I try to do it, I'm going to embarrass myself. So I apologize for that, but I don't have the paper in front of me. But
don't worry. And I know
there's
that
a couple that are,
you mentioned. No, go ahead.
I was going to say there's a couple that are interesting, and scientifically, it seems that some of the pathways that get mutations later on in the gene process, in the disease process, are affected early on. So it looks like MYC, again, is a gene that's deregulated. You can inherit variants that affect the way MYC behaves that may predispose you to developing myeloma.
And is MYC associated with a particular translocation, or is it's just present across?
Yeah, we've described there's a kind of there's a load of translocations into MYC that really hasn't hit prime time. We've just sent a paper off to Blood, and 20% of patients present with a MYC translocation, and again, it's another one of these poor prognostic lesions. But people aren't even aware of that or testing for that as yet.
Is this the new 717 translocation?
No. This is nothing to do with the immunoglobulin genes. It's due to translocating kind of different parts of the genome in front of MYC, which make it get upregulated and sort of drives the cells to grow faster.
Okay. Well, I've taken a lot of time asking you about your research, but would you like to talk about your clinical trials, the ones that you have open right now?
Wow. So we are trying to do a number of things with clinical trials. So one of the things I'm interested in doing is pomalidomide, great new drug. With dexamethasone, you seem to get responses in 30 to 40% of people. It would be good to have a test that said this is one of the 30 to 40% of people who are going to respond. Or you could look at it the other way around, which is how can we identify before we start treating people those who aren't going to respond, because you're wasting their time, you're not active against the disease. So identifying non-responders to a drug would be really interesting. I'm also interested in maintenance treatment. I think maintenance looks like a really good way forward to me. The Revlimid as maintenance, I'm convinced with the results that it does improve outcomes, does improve overall survival. There are a number of studies that are already there. There'll be new data at ASH. All of it's consistent with Revlimid being a good approach for maintenance. Personally, I'm interested in looking how these new oral proteasome inhibitors function to improve the outcome of myeloma by using them in the maintenance setting. So we're trying to set up a maintenance study that addresses that question. So all of these questions I think are important, and we have a network of centres in the UK where we try to do studies together so as we can kind of bring these new drugs close to patients, so as they can access them close to their home without having to travel to tertiary centres.
And when it comes to maintenance, I know I know this might be popular now, so I guess learning more about it. Do we want to do maintenance for how long? How long are we talking? And so, is it a lower dosage?
So I think some of the important characteristics of maintenance are that it doesn't impair the patient's quality of life. I think quality of life is really important. It's difficult to know. If you use something for 6 months, that's not really maintenance. That's consolidation aimed at reducing the amount of the tumour cells present. Sometimes you might consider that continuing treatment until disease progression really is what maintenance is about, because it affects the biology of the disease. So I've got a lot of sympathy for continuing maintenance until disease progression, but you can make arguments for doing it for limited periods of time, like for 2 to 4 years. There's no specific answer to your question, and only time and good clinical trials are really going to address what the best way of doing it is. But it looks very much like when you get into a remission, that maintenance is a very powerful way of keeping you in a remission long term.
And maybe we can talk about that for the importance of clinical trials, because I know with over 400 articles you're running and clinical trials, you're running many clinical trials. So how important is patient participation in clinical trials for you?
It's really crucial. The patients, so again, we have I would say powerful, but I think that's the wrong word. It's a very helpful, informed patient organisation in the UK called Myeloma UK that actually provide information to patients. They vet the trials to see that the trials are useful for patients, and they encourage patients through their information to partake in clinical trials. And so clinical trials are a really important way forward. You really should, if you're going to treat somebody, you need to use that as an experiment, really, because the experiment is, if a patient does good, why did they do good? And if you can learn from that and use that to make the outcome of the next patient better, then that's a very positive thing. And most patients would encourage their doctors to behave like that, to collect information, review their results, and use it to improve outcomes.
Mm-hmm. Well, the reason we started this series is because I think if with less than 5%, maybe more like 3% of patients participating in myeloma clinical trials, it's just going to take a really long time to get to the conclusions that we need to get to. And if we can do something as patients, I guess a follow-up question, and probably my last question, will be, how can patients help you further your important research?
So the really interesting thing about patients is that they always want to help. If you ever ask a patient, can we do this? Do you mind if we do that? They always agree, and yet a small minority of vociferous people have kind of made the whole environment about getting tissue from people, studying it in the laboratory, entering into clinical trials. They've made that all very top-heavy with legislation, which has slowed down the kind of ability to set up a clinical trial and to look at material. And so I think the silent minority of patients who I know to be helpful should speak up and encourage clinical trials and encourage biological studies based on their samples. And I think patients and patient organizations can do a lot in that respect.
Well, we are happy to help.
Thank you. As always, like I said, patients always want to help, and they do.
Yes, because our lives are on the line, so we have a very, very vested interest in helping. Okay, well, I would like to open it up for caller questions. I've taken up a lot of time, so I don't know if we'll have time for many, but if you have questions about Dr. Morgan's research, you can call into 347-637-2631, and once you're on the call, press 1 on your keypad. And I also have a a question or two that came in via email. So, the first caller, go ahead.
Hey, Jenny and Dr. Morgan, thanks for taking the phone call. It's been a pleasure listening to this, and it's at some levels it's been one of the more exciting interviews as we think about getting into the details of personal medicine. So treating mutations rather than treating the disease it hit me like a ton of bricks. So do you have any plans to run a trial that is gene specific, or do you know of any trials that are gene specific?
So I think Bart in Little Rock is thinking about taking patients as they come into his high-risk studies, doing mutation analysis for actionable mutations, and then really thinking about adjusting the treatment based on the presence of those mutations. And the key sort of candidate gene currently is probably MEK inhibition and inhibitors that target the RAS pathway. It's scientifically the fact that 50% of all myeloma patients have RAS mutations has to be meaningful about something, I think. And so I think it's a clue that we can't afford to pass up on.
Okay. And so that's the Little Rock. Anything other than Little Rock?
I don't know. In London, we're trying to do something similar for high-risk patients, but I think it's still not really at prime time as yet. But I think it'll take off over the next 1 to 2 years, and it will become very commonplace in that time.
And I have a follow-up question for that, I guess. Would there be any benefit to constructing plasma cell leukemia kind of trials that involve myeloma patients?
No, I think so. I think that falls into the high-risk kind of disease. I think, it's difficult for people when they get plasma cell leukemia because that, we really don't know what's the best approach, and we need to maximize the chances over time of improving the outcome of plasma cell leukemia, people with extramedullary disease, people with metastases in their liver. All of these are really important questions.
Well, it just seems that go ahead. Sorry.
I'm sorry. I just want a follow up to the other question. And this is maybe off into the weeds, and so you don't have to answer it. But I've read about patients organizing themselves into patient-organized trials, and I know that's probably fingers on a chalkboard to a doctor. So, but like, what if the patients got together and I'm not suggesting this is a great idea, just a question, and organize themselves into the different mutations, and if there are,
I get what you're saying. I kind of think it's a very interesting kind of idea. So part of the issue with being a doctor is that we're self-interested because we're doctors in treating people and our own ideas. And politicians, healthcare providers, you name it, they kind of don't always give doctors the credibility they deserve. If you're a patient or a group of patients with a specific variant, it's very difficult, I think, for providers of any sort to ignore patient power, because you're the ones that have the issues, you're the ones with the disease. It is all about you, it's not about doctors. And so it's not such a bad idea. How it would pan out, I have no idea, of course, but it's a sort of interesting approach.
There'd be cats and dogs raining in the streets. It'd be pandemonium.
Yeah. The lunatics in charge of the asylum.
All right. Well, thank you for taking the question.
You're welcome.
Okay, thank you. And maybe a related email in question from Sandra was how, if someone wanted to join an international trial like yours and lived in the United States, how would they go about doing that?
There's absolutely no infrastructure or legal framework to allow it. And that's a really incredible thing to say, that you would need legal frameworks to do like that, because you'd think it would be the most simple thing in the world for somebody who wanted to go onto a trial to go onto it. But the rule makers have made it really quite constrained, and they've made it very difficult, I think. And I think we need to pull back a little bit from the current legislation, which is aimed at protecting people, but it's protecting people so much these days that it's slowing up the pace of change in research, and I think it needs to come back a bit more to the midline.
So if someone wanted to join your trial, they physically couldn't, they wouldn't be allowed in it, or they would have to pay for it themselves, or what do you mean? So
they would have to be in the UK, in the UK healthcare system, and the trial would have to be approved in that hospital. They'd have to have their treatment in that hospital or one of the hospitals where the trials were being run. Otherwise, it would be really, really difficult, and that's an issue across Europe and across the different states in the US as well, I think.
Well, that's fascinating, because I would have never thought that. Well, wow, we have taken a lot of your time. We are very, very grateful for your research and for your participation. And we are all looking forward to your learning more about personalized medicine for myeloma patients. We are eager to help you make it a reality. And we wish you the very best in continuing your excellent research and work.
No, I'd like to thank you for your kind of hospitality, your insightful questions. You didn't make it easy for me, but it was educational, so thanks a lot. Thanks for this, and look after yourself.
Well, thank you so much for your participation.
Bye.
Bye-bye. Thank you for listening to another episode of Innovation in Myeloma. Join us next week for our next inpatient video interview as we learn more about how we can help drive to a cure.
Hey guys, it is Ryan. I'm not sure if you know this about me, but I'm a bit of a fun fanatic when I can. I like to work, but I like fun too. It's a thing. And now the truth is out there. I can tell you about my favorite place to have fun. Chumba Casino. They have hundreds of social casino style games to choose from, with new games released each week. You can play for free anytime, anywhere, and each day brings a new chance to collect daily bonuses. So join me in the fun. Sign up now at ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.